Assalamu alaikum. Thank you very much, Wasim. Great honor to be on this important session. These guidelines were just been published and presented a few weeks back. The conference was late in September, and this was one of the mega presentations at the conference. What we will do in this session, we'll split the task between myself and Professor Inas Shaltut to cover the aspects of the presentation. I will cover the glycemic control, including the obesity section, and Professor Shaltut will cover the high-risk cardiovascular and renal persons. So this is the consensus group, the authors of the recommendation, and here are the two references for you if you wish to download the whole document of the presentation itself. It's just a reminder that it's a consensus report. So it's not Quran. We can criticize, we can disagree on some of the points, but certainly the level of evidence with 346 references and the amount of time and effort they took to come with this document makes it one of the most important documents in the management of diabetes in general. The focus nowadays is not just about one side of diabetes. It is certainly 4 different levels. I will focus on the first 2, the glycemic and the weight management, and as I mentioned, Professor Shaltut will cover the cardiorenal prevention and protection and management as well. So the first important point, this is the sequence of how they presented. And to me, this is a shift, because for the last 5-6 years, we've been constantly just focusing in our thoughts on the cardiac and renal issues. To me, it was a subtle hint that glycemic management is very important. So they started the presentation with the importance of glycemic control. Of course, we do not want to be glucose-centric, but equally, this is the hallmark of diabetes, and it needs to be addressed. And they are just reminding us, whether in type 2 or type 1 evidence, whether it's a DCCT or the UKPDS or others, that good glycemic control is essential for prevention of complications and for quality of life. Another crucial point they're moving to stress upon is that the glycemic management must take into account the behavior approach, the medication, and the metabolic surgery. So metabolic surgery now is part of our thoughts on how can we best manage a person with diabetes. Understanding the buzzword here is the complexity of the person with a centric approach. Weight target as an intervention for glycemic control. So just stop here for a second. It is not weight target to look smarter. It is not weight target for anything else. It is weight target for improvement in glycemic control, as well as in the other parameters that weight will have an impact on the person with diabetes. So this is not obesity management in obese people per se. This is obesity management in people with diabetes. And of course, the start of saying it's significant is 5%. So weight reduction less than 5% will make the person happier, but will it make difference in clinical outcome? It needs to be 5% as a minimum, and ideally, as I highlighted here in blue, loss of 10 to 15% of body weight can disease modify, in fact, and lead to remission of diabetes. Remission of diabetes is very important. We've heard in the earlier session about the prevention of diabetes and the reversal of diabetes from Florent Totti. And here, what we're talking about, that's the possibility as well with 10 to 15% reduction in the weight of the individual. And also, it carries other benefit beyond just the glycemic control, certainly benefit for the cardiometabolic. So, as usual, the center of the approach is the person with diabetes. And they stress upon we should not call them patients with diabetes. It's a person with diabetes. They are only patient when they are seriously ill, for example, in hospital. So these aspects of the NICE circle are something that we all need to think of. I cannot go through all of them in depth because the time we have for the conference, we probably need to dedicate a day to discuss in depth every single step. But it's important to remember all of them. The person key characteristics, the specific factors that impact the choice of treatment, the utilized shared decision making. So it's not me dictate what I see right for my patient. It's a joint decision, agreement on management plan, and then we implement the plan. It's all well and good to say to the person, you need to lose weight. But what are the measures we will do to try to get the person to lose weight? Providing ongoing support and monitoring, and that's really very important. And of course, review and agree on the management plan on a regular basis. This is one of the points that we unfortunately are missing in many countries. Diabetes self-management, education and support. We all have smartphones, we have laptops, and we need a brief on how to use them. A person with a complex condition as diabetes need a serious brief on how to do this. And we must encourage and endorse diabetes self-management by making it as important as the other aspects of diabetes care. We need to identify and know how to access local diabetes self-management. And unfortunately, this is terribly missing, although it is the least of the costs. I recall some photos of diabetes education from colleagues here from the EASD in a simple room or in a mosque. So education does not need lots of facilities. And of course, we need to impress upon the person with diabetes that talking to other healthcare professionals is essential, and of course need to be done at the time of diagnosis, on an annual basis, and whenever there is a change in the circumstances of the person. Another key problem is that we frequently have inertia. We give so many soft excuses to why the glycemic control is high. Oh, it was Ramadan, it was Eid, doctor. I just came back from my holiday. And we forget that the HbA1c is 3 months, 12 weeks of average HbA1c. So it wouldn't be a few days of a problem. So that's a chronic condition, a chronic problem, and inertia should be eliminated from our practice. So come first to the first part of the weight management in people with type 2 diabetes. There's been recently 2 very big studies, one on semaglutide, 2.4 milligrams, not the 1 milligram we use and license currently for diabetes management. It is the higher dose of the 2.4 milligrams. And at the same time, there is tirzepatide, which is a very new drug, launched only so far in 2 countries, USA and United Arab Emirates, where it's a combination of GLP-1 and GIP. And as you can see from the data, you are talking here about 10 kilograms of weight, 10 to 11 kilograms of weight loss in an average person with diabetes. So this obviously is very remarkable. They also talked about metabolic surgery. Metabolic surgery have, in well-selected persons, not for everyone, in well-selected persons, have a very long evidence-based outcome that have lasted for over 10 years now, with 30% loss of the weight in some people, as you can see from the last slide. Unfortunately, medical therapy does not have the same longevity of effect. People stop dieting, stop the practices that they do, but obviously with surgery the situation is different. So here is their algorithm for what should we do for management. Copy this, take a photo of it because it's important. It says, number 1, set a goal. So talk to your patient and agree a goal. Number 2, you have to think of the lifestyle changes, the nutrition plan, the eating pattern, the physical activity. And physical activity is a key. So many people are hardly active in our region. The level of walking or any other physical activity is very low. And then we need to provide them with a structured program, not a few discussion, 5-10 minutes discussion from me. It needs a structured program. And eventually think of medication or of metabolic surgery. And of course, when we need to think of medication, we need to think of medication that will do two things. تضرب عصفورين بحجر. Hit two birds with one stone. Very strong on glycemic management and very good on weight reduction as well. They have spent a good time and good slides, and I invite you all to review this document on what type of physical activity. So you are all sitting, and they are encouraging, if you're in a situation where you're sitting for a long time, get out of your seat every 30 minutes. Just walk for 1 minute every 30 minutes. Between patients, stop, get out of your room and walk in the corridor and go back again. That disturbs the sitting process. Walking, of course, exercise is very important, and they have specified the total duration that is required, which was 150 minutes, and that it should not be in just one go. So someone young and fit and go to the gym on the Friday and spend an hour and a half, that's not the ideal scenario. You should not have more than 2 days with no physical activity. And they here talk about something very important that we see in many people with diabetes: sarcopenia, the huzel, the loss of the muscle, and the replacement with just fat, which we see in many people, and that make them lose strength, energy, and also relate to comorbidities. So they are talking even 500 steps per day can be associated with 2 to 9% reduction in cardiovascular risk and all-cause mortality. 500 steps. That's, for the sake of the argument, that's a short distance between the home and maybe the nearest mosque or metro station or something like this. 5 to 6 minutes of brisk walking can reduce or equates to 4 years greater life expectancy. We always talk about people with diabetes lose 6 years of their life. Now, simple 5 to 6 minutes walking can regain 4 of these years of being lost. Of course, strengthening exercise and type of strength, and the easiest is the stretch band. The stretch band is something that people can buy while they're sitting watching Amra Adib. They can just keep doing this with their arms or their legs, and it will help without having to burden themselves too much. Sleep. First time now we focus on these important issues. Too much sleep, more than 8 hours, is not good. Sleep less than 6 hours is also equally not good. The people who are up all night and sleep during the day, the chronotype of the night is not the ideal scenario. And of course, uninterrupted sleep is very important. I know that this is difficult. Many people with diabetes have the need to wake up to go to the toilet for various reasons, prostate, diuretics, weak bladders, whatever. But as much as possible, we need to try to make it as uninterrupted sleep. Now we go to the glycemic management as we know it. And here is their algorithm that they have put. The right part of it is for the weight, the left part is for what we should do. And I will come to that again. Metformin, every class of drug, they quantify the effect of the drug in so many aspects. The efficacy, the rates of hypos, change in weight, effect on MACE, heart failure, progression of DKD, diabetic kidney disease, dosing, use, and consideration in renally impaired, whether it's oral or not, and cost, which of course is crucial. And of course, metformin is traditionally, and think here of the word traditionally, because it is no longer as a must to be the monotherapy to start with. But classically, for the vast majority of patients, it is for all of the obvious reason. sulfonylureas get a decent recognition by EASD and ADA. What do they say about them? They are high in efficacy, inexpensive, accessible, but they also warn us that it's not heterogeneous. Not all of them are the same. They have no impact, negative impact on MACE. TZDs also get a very good note from the point of their efficacy and effect on NASH, as well as their potency on effect, as well as second option for cardiovascular if SGL2 and GLP-1 are not available. DPP-4 inhibitor, they got the praise for the combination and being neutral on effect. SGL2 and GLP-1 will be covered well by Professor Ines in her presentation, but they just highlight to us some of the important points. We now have oral GLP-1s. We now have studies on higher doses of GLP-1s, such as the 2 milligrams of semaglutide and as well as the tirzepatide. Tirzepatide got a strong mention here. I know it's not relevant to you guys, so I will, because it's not available, it's not launched in the country yet. So people who need it will need to go to different countries. Insulin, they say something very simple about insulin. It's the only lowering glucose, the advantage of being dose dependent in lowering. So you can get from an HbA1c of 15 to 6 if you want. That's not the case with many or any of the other drugs. Of course, it has the risk of hypos and the risk of weight gain. And they also highlight to us it is neutral. It has no negative impact on the heart or on the kidney. Combination therapy get a very important mention. We need to use combination therapy when required, not necessarily for every single patient, when required for all the advantage of combination therapy, different drugs, different mechanism, reducing the problems of counting tablets and saying far too many tablets. So again here, the glycemic control point, they specify what we should start with. Metformin is the initial for many, but not necessarily for all. We need to think of efficacy. Some of the drugs with very high efficacy, some of the drugs with just high efficacy, and some are with intermediate level. I have 2 more slides. So starting insulin, they are saying that if you want to start insulin, you need to think first why this person is not on a GLP-1. Well, of course, so many patients cannot afford the GLP-1s. But if you start insulin, they recommend, of course, to start with basal and then think of the meal time. I personally have a different view to this, but that's not the discussion for now. My final slide is, diabetes is not just a doctor and a person with diabetes. There is a full team. Integrated care is very important. We need to address the problem with the input of educators, dietitians, pharmacists, psychologists, a big team to help a person with diabetes achieve the goals that they need to achieve. Thank you. I stop here and hand over to Professor Ines.